Welcome to the Community Voice, connecting you to your community and each other. I'm Fara Sax. Joining me today in the studio is Dr. Vangie Texidor. She is a board-certified surgeon with TM Surgical in Doral and affiliated with Heredity Hospital. Thank you so much for coming, and it's a pleasure to meet you. And I'm sorry for a little bit of the delay that we had this morning.
All good. Thank you for having me, Farah. Nice to meet you.
And I also want to thank our beloved
Paola
behind the camera who sets it all up. She's a miracle worker. Thank you. Tell me a little bit about what your role is at Heredity and what you do.
So we've been working on starting a women's center so that we can make it more of a one-stop shop for women when they have to go through breast cancer screening. And once they're diagnosed with cancer or diagnosis that do have to get surgery, even if they're not malignant, so that everything flows better and they have to go through less effort and less heartache to get studies done and to get referrals done to different subspecialties, specialties that they have to, be seen by, so that everything is just easier and we can give better access to the patient and make things less difficult with already a diagnosis that can be hard to manage.
So what we're talking about is breast cancer. And what we're talking about is October is Breast Cancer Awareness Month. And I really believe in my whole heart that October is 1 month out of 11 months out of 365 days that women and men have to be vigilant for their health and worrying about or thinking about and considering really paying attention to their breasts so that, we catch it at the early stages. So with that being said, what should every person know about breast cancer?
I think screening is the most important. Nowadays, imaging technology is so good that it allows us to detect changes that are already malignant when we're not able to palpate them.
What does that mean to palpate?
To touch it. Like you don't feel a lump, you don't feel anything at all, you don't have any symptoms. Normally, cancer does not cause pain, which is something is very common to have breast pain for normal reasons, in response to hormones. A lot of people get scared because they get breast pain, and it's really rare. You would have a very advanced mass that you probably already can feel, if it's causing pain. So imaging allows us to see something that's so tiny, a minute, that we can get it very early on nowadays. So screening, a lot of people are scared and they want to do things so they don't find out, but it can save you a lot of treatments and a lot of surgeries perhaps, and we might be able to get it out and resected when it's so early that you're going to be cured. Okay.
That's really an amazing, because we always think like, how does it start? How does cancer start? It's this tiny little thing, and then it just goes crazy in the body.
So for the most part, it's just cells that start growing out of control. So once you start, we think of cancer as a tumor and as a mass, but when we catch them so early, it's not even a mass yet. It's barely like a blur you see on the imaging. And like you see maybe microcalcifications that look like little tiny stars. And when you do a biopsy, you already have malignant cells. So it doesn't necessarily, we don't want it to get to the point where you actually have a tumor you can feel.
Because I know my grandmother of blessed memory, she had cancer, and this was many, 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 many years ago we're talking about, and the treatment was probably very different, and they catch it later on, and here we are, fast forward in 2021, the pandemic just, the dates, what is this, 2019, what is this?
Yeah.
But the treatments are probably very different from when my grandmother had this.
Not only imaging is a lot better now, so we see things that we couldn't see before earlier. But now we have a lot of other tools and instruments that we can use to fight the cancer, or attack it, if you will. So I get a lot of patients sometimes that maybe their sister or their mother or aunt had 30 years ago breast cancer, and they come in so scared because of what they went through. And nowadays it's so different how we can treat it and how many things we have to manage it so that you can get cured. Before, like maybe 30 years ago, it wasn't as common, and they would think of breast cancer as a very bad news, and like that was it. So nowadays it shouldn't be like that at all, especially if you follow up screening.
So they, at those days, I think it was a death sentence. Really,
correct.
I mean, women considered that as really that's the end. And so, how has the technology changed? What do we do? What are you doing differently with your patients? Can you walk us through some of the steps that I feel a lump, I don't feel a lump, or I've had a screening, a diagnostic screening, and maybe we should start there. What's the difference between a screening and a diagnostic screening?
Okay. So screening guidelines have changed a lot also over time, and we can go over those, but it starts with a mammogram. The actual screening image modality is a mammogram. So we do, from the side and from the top, images of your breast, and we go from there. So most women, that's the only thing they might need. If we see something that the radiologist is unsure about, or they're like, we need to characterize this better, I need different angles to see really what I'm seeing, or describe better what I'm seeing, then we go into diagnostic images, which will be the ultrasound. Even though a lot of people get it since the beginning, it's always a diagnostic tool or image, or the MRI.
Is there a better screening, like a 3D versus what's the difference between that? Because I see that seems to be more happening now, like these 3D, everything is changing. Like every time you go for a mammogram, every year it's like, something new.
Yeah.
Which is great.
Yeah. So 3D images do get a better, you get a better view, or you might see things that you couldn't see on 2D. So we're starting to move that way. A lot of people we just do those nowadays. Sometimes we still have issues with insurance covering it, but it's moving that way, where we're just going to do 3D eventually.
And how young should one be to get a mammogram screening?
So in general,
I see that like there's a hesitation, there's a smile, and there's a pause. I got that from you just now.
So depending on what guideline you're following, there are different organizations with sort of slightly different recommendations, but they all fall within certain generalized recommendation, let's say. So between 40 and 49, some of the guidelines tell you want to start already discussing this with your PCP. You should make an informed decision based on whether this is what are the benefits of getting imaging, already at 40, and what might be the harms of getting imaging, or what might come out of it that might not be good.
Like what is that?
Well, normally you're doing imaging earlier, so you're doing a breast that is more dense. Many times you're going to see things that they might recommend a biopsy on, a needle biopsy, and it probably is going to be negative, or sometimes it's negative. So you end up getting more imaging done or you need screening images because they're unsure. So you end up getting more studies and maybe more biopsies than maybe were necessary. So, but at the same time, if you get imaging done at that time, you might be catching something earlier on. So once they make that decision, and this is for average risk women or men, once they start, it can be every 2 years, or depending on the one or the guidelines you follow, between 45 and 49, then every other year or every year. Okay. Once you turn 50, organizations tend to agree more on that side. Then you want to do all the women between either annually or biennial, every other year. So that also is going to only apply for people who are average risk of breast cancer. If you're high risk, that changes a little bit.
And what is that? Who is the high? What would make it a high risk? Was it I heard a lot, your maternal, your paternal grandma, your mother. I mean, how does that, is it followed by lineage? Is it a hereditary? Is it genetic? What goes on?
Some people might have a genetic component. Like everyone knows the case of Angelina Jolie. So she had BRCA gene positive. So you're almost for sure you're going to get breast cancer. So you want to do something about it before you develop it.
Is it just is that considered just for breast cancer, or is it for ovarian cancer, cervical cancer? Is
depending on the one you have, it might increase the risk of ovarian as well. So they might decide to do different surgeries to prevent. But also people who as a kid had chest radiation because maybe they had a lymphoma. Those are high risk of developing breast cancer down the road. People who have very dense breast, and then family or genetic predispositions as well.
And let's talk about like what are the stages of cancer? I mean, there's early detection where you can do something really proactively quickly, and then take me through that. What does that look like for?
So staging
cancers
nowadays for breast cancer has become more and more complex as we've gotten more tools to work to treat it and diagnose it.
It's interesting. It's like a double-edged sword. It's like the more you know, the more you find.
Because now we have more things to attack it in a way. So staging really varies a lot. It's not like that simple. Now receptors on the tumor play a factor on your staging. In general, you go from 1 to 4 in staging. And it's funny because that's kind of the first question a lot of patients make when they get a diagnosis and they come to see me. And sometimes you even you might have an idea of where they might lie on based on the cancer size, on the tumor size, but you're not sure yet until you get everything done and you get the actual surgery done, and then you can get a final staging. Because three things in general come in play when you're staging a tumor size, if it has traveled anywhere, and if the nodes are positive, which normally in breast you see a lot axillary nodes, that when the cancer travels, it goes first to axilla. So once we have all that information, we can give an accurate stage. But now, a lot of breast tumors have receptors that respond to hormones, estrogen, progesterone. So depending on whether those hormones, those receptors are present or not, we have another medication that we can treat to block the cancer from growing, and it can decrease significantly your chances of getting a recurrence down the line.
It's interesting. This morning, or was it last night, I just saw a study that came out of Israel that there's an injection that they're going to be considering from the FDA in America. So I was like, for cancer, and I was like, for breast cancer. So I was like, that's exciting.
Every day new things come out. So you have many ways of attacking it from different angles, and they all have different names. And it's very overwhelming for a patient when they first come in to see you and you're like, okay, I recommend surgery, or maybe later, maybe now, or maybe you need chemotherapy first. But these are all the factors that we have to consider, and these are the things that we have that come into play to make a decision. And it's a lot of new information for the patient, and it makes everything a little bit overwhelming. So you're not just getting a breast cancer diagnosis, but you're getting all this new information, and it's difficult to make a decision when you don't really understand all of this.
Absolutely. And how is TM Surgical and Coralty Hospital? How are their facilities in handling?
So we're trying to get, number one, increase screening awareness and get people to get their images done, which we were talking about with COVID. A lot of people, it's been a year and a half, and they haven't had any imaging done.
And then what happens? It exacerbates the problem even further.
They get here, and maybe a tumor that could have been caught super early, now it's like a little bit bigger now. It's still manageable, but you could have, treated this earlier on. So we provide a place where they can get the surgery, they can get diagnostic imaging. We have a liaison with radiation oncologists, plastic surgeons for the reconstruction when that's an option, or the choice the road they want to take. And it just, a lot of people try to get a surgeon, for example, and it might be 2-3 months before they get seen by the doctor because they're treated and seen and can get advice and make a decision much faster, as it should be.
And I'm thinking that the waiting is the hard, as the song says, is the hardest part, because the mind just probably goes crazy of what could be, what if, maybe if. So
that's an important point, because we had talked about this before. So cancer is never an emergency for the most part.
Say that again. Say that again, because when you see cancer, the big C, you go, wow, it's. Say that again.
It's never an emergency, almost never. So cancer grows slowly for the most part. So this has been growing from the first cell that went the wrong way for months, maybe years. I've seen patients who already had changes on a mammogram and recommendations for a biopsy 3 years ago. And finally, they reappeared this year, and now they have a large cancer. So this has been growing for the last 3 years. So you don't want to be waiting 3-4 months to get things done. You want to get it done as soon as possible, but you don't have to be seen today. nothing's going to change. It's not going to make a difference in your diagnosis. It doesn't grow from one day to the other and suddenly now you have metastasis. It doesn't work like that. So it's very typical that once you see a surgeon, the average time from seeing me, for example, to getting your surgery done, because of so many things that we have to get done to get to surgery, it might be 6-8 weeks. So that's normal, and nothing, bad happens because of that waiting. You don't want to wait 5 months, but you start things rolling. You want to get the evaluation by the oncologist. Sometimes patients are unsure when they have both choices, whether they want to do a partial mastectomy or a total mastectomy. And then that involves, if I do a partial, I need radiation. So let me go and see a radiation oncologist. Or if I do a total, I get reconstruction. Let me see plastic surgeon. So it's a lot of coordination between a lot of doctors, the facilities. So a lot of things come into play and it takes time. And there's no rush. You don't want to, sleep on it, but, things get done slowly, and you get there.
That's reassuring. What are some of the warning signs that women should be on the outlook for possibly having this diagnosis, and even men? We forgot about that gender somehow with men also having breast cancer.
So in general, obviously for men, we don't do screening unless there's a genetic predisposition known in their family, and they might be positive already, and we know that. In general, screening is so good nowadays that we should be able to catch this and see it way before you get any kind of changes. But in patients that maybe are not following up with their screening, and maybe men that had no genetic predisposition, if you ever feel a lump, especially if you feel it's growing, if you have any skin changes, like your skin looks like an orange peel, if very rarely pain, but it could be, you want to go to your doctor, to your PCP normally, and get exam and get imaging done so we can take it from there.
And what kind of tests are available to detect this cancer?
So for the most part, we start with the mammogram, even for men. Whenever you feel when a man presents with a painless lump, it tends to be behind the areola, and they need to get a mammogram. So even if you think they don't have enough tissue to do a mammogram, that's the first step in management always. And then if there's the radiologist is always going to give you the guidance or like the recommendations of what you have to do next and what you follow up with. So if their recommendation is a biopsy, you take it from there. Or if they're like, this is benign, I'm not worried about it, unless physical exam from the doctor really says something different from what the radiograph or the imaging is saying, you follow what the radiologist's recommendations are, and you almost always nowadays start with needle biopsies. I get a lot of patients that were used to, oh, you have a lump, let's just go ahead and take it out. And I have a lot of patients with breast surgeries or breast biopsies that were open and surgical. So there are very few indications nowadays to do that. You first go to your breast radiologist for the most part, and you get a needle, a biopsy with a needle with local anesthesia, and the image guiding you to get to that lesion because you don't see it or palpate it many times. So.
Wow, that's really changed. It's really changed. And we talked about a little bit about cancer as a hereditary. Does it run for women's lines, men's lines, grandma, grandpa?
It can come in from anywhere.
So it's not. So it's really that's disseminate that a little bit for us.
The most typical, just because women in general tend to have more breast or more breast tissue, they're gonna have a higher risk than men in general. But if that side has BRCA positive gene, maybe your dad had it, and you might have it. So the risk in that sense is the same as if they're coming from your mom.
So that's through a blood test? Is that how you find that out?
So, for example, I do with one of the companies that provide genetic testing. I have their kit in my office, and just by spitting on a little bottle or vial, they spit, we send it to the genetic center, and they give you back results. So it's that easy. It doesn't necessarily have to be blood. And then, which is like a little bit further out, but once we get pathology and we get either the breast biopsy or the actual mastectomy done, You can get, for some of the cancers, you can get genetic testing on the tumor. And that might give you also an idea on whether this cancer, like how likely it is to reoccur. So that's another tool that we're using nowadays. Like, oh, it's very unlikely you're going to get recurrence on this. So really, chemo or radiation is not really going to help you. So we can avoid it in these patients. Or you're very likely to get a recurrence. We have to go through all of this.
And then also, let's talk about breast monthly checking to see where you are. Is that like, because I haven't heard much about that. You pick your arm up in the shower and is that like a thing still?
Evidence has taken us a little bit away from that.
Wow, I am really archaic.
No, but you would be surprised. Most people come in thinking that. And it's not to say you shouldn't check and be aware of like what's normal in you and be able to identify something that's new. But if you are following screening guidelines, you should never get to the point where you're feeling something that wasn't seen on images, almost always. Okay, so there's been no proof so far in studies that doing self-breast exam or by a doctor decreases like how you're gonna come out with a breast cancer. Or like how you're going to do later on, or your prognosis.
And, you said that it wasn't like a house on fire that you need once the diagnosis, but what advice would you give to someone that was just diagnosed and like, what do I do next? And how do I move forward? And how do I keep centered and grounded?
So on the other end of the spectrum, I get a lot of patients come in denial. And they're mad, and they get mad at the doctor who gave the diagnosis, and then they want to get a second opinion, and they don't believe you, and they're like, how do you know that biopsy is correct? Chances of that being correct, very low. So
being incorrect.
Incorrect, yeah, or like having being exchanged for another patient, or those are things that.
But that's a normal. Isn't that a normal response? The denial is really denial is really normal.
I think. It's part of the process.
Yes, it's a defense mechanism.
But then you see people who are like, no, let's just deal with this, okay? And that might be, obviously, it's not that you control it, but that's the best way to go about it, because when you're in denial, you end up many times losing months of, maybe you could have had 3 months ago surgery or started chemotherapy. And because you're shopping around and you don't want to believe anyone, sometimes even the family members are in denial. So it's really hard dealing with that part, because you want to help the patient, and they obviously they don't trust what anyone's saying right now at first until they get there. So it's really important to, especially for the family, to try to support the patients, instead of telling stories of the neighbor and the uncle and all these stories they know of someone who went through cancer. Every cancer is so different, and nowadays breast cancer doesn't tell me anything. It has a name and a last name and like a middle name. So everything, how you're going to respond, what your prognosis is, depends on receptors, depends on your node status, depends on your tumor size. So you have so many components coming into play that I think the best thing once you're diagnosed is to like not listen to anyone, because you're going to end up freaking out. And that happens a lot. It's almost inevitable. And everyone wants to give you a recommendation based on their experience or their life. And it normally doesn't help. You want to have the patient, okay, let's get this done. Let's attack it, have a good, positive attitude towards it, so that you can go through what already is anyway something no one wants to go through it, and it's difficult, in the best way possible.
And having had my grandmother had breast cancer, as I just shared with you, and my father passed away in December from other cancers. Thank you. But what I found was, as a caregiver, that dealing with that person's cancer and how they want to be dealt with is really trying. And if, like you said, everybody is completely different on how they deal with themselves or how they deal with their family members and how they deal with that cancer. So what advice would you give to caregivers that have to support their loved ones during this fight?
Obviously be there for them, but I would say as much as possible. Some people are going to get depressed. Some people, are going to be down for some time, are going to be in denial. So I say be as positive as you can and try to get them away from that hole they get into, so that things can go better. And I think like attitude and how you go about it makes a big difference in how you do with treatment as well. So,
and I'm sure that what you're doing, not only are you a surgeon,
Mhm.
one of the few female surgeons in South
Yeah.
Florida, kudos to you, girl
Thank you.
power. You probably see that the emotional response from both the families as well as the patients.
And in the same way, I have some patients that are like that are like, let's get this done, let's deal with it, like get rid of it, and then they don't want family to know, and this applies to many cancers, because they don't want to be pitied. So they don't want people to be like, treat you differently, or like you're gonna break, or no, you cannot do this. Why? I had an elderly patient who was so sad because he was dealing already with, I don't know, prostate cancer, and the primary doctor had told him, you can never drink again. I'm like, you can have a beer, it's okay, you don't have to stop your life because you have cancer. You're gonna manage it and everything under moderation, but you many things can continue to be the same way they were before.
So it's a life that does not have to stop. It just
No,
needs
it
to be adjusted, detour, and move forward.
And it's difficult, and some things are going to change for some time. But I know people who, you want to keep working and you want to keep having your life as normal as possible. If,
absolutely,
as long as your circumstances allow, so that you get, for example, if you're going through chemotherapy, depending on how they're giving it to you, maybe that day you're tired, maybe next day you can already go back to work.
Right.
And nowadays, at least COVID has done, the only thing it's done good maybe is that now a lot of times we have the possibility of working from home. So maybe you're tired and you don't want to be driving, but you can work from home on your laptop. So you want to try to keep life as normal as possible during that time. So you keep, positive, and you keep feeling well, and
keep
that
living.
helps. Yeah.
And keep living.
Because otherwise it's, anyone will get depressed if you're home and you're not doing anything, and
Absolutely,
you're not going
100%.
out, and there's no need.
100%. And we have a couple of seconds left. Tell me something that I haven't addressed so far and that you haven't shared that you'd like our audience to know about you, about Heredity Hospital, about TM Surgical.
Okay. So I think the most important, we're trying to focus on education, on having everyone be on the same page, on the PCP starts with the PCP, and having them know when I have to refer this patient to a surgeon, when I have to give them reassurance, be like, you're okay. It says the biopsy is benign. We don't have to do anything about this. So that we can give the patients that do need to get surgery, an appointment right away. And we're not seeing patients that are not surgical, for example, that are benign conditions, and we're booked and we have no space for those patients that really do need to see us soon enough. So I think the most important, we're trying to streamline everything and give quick access to all these specialties to these patients who need it.
And I know that not only do you deal with cancer, you deal with so many other things, and I'd like to have you back again.
Thank you.
But where can people reach out to you and Heredity Hospital for more information? Should they need to continue this conversation, which I hope has been very, very helpful for those that might be affiliated, that might have a diagnosis, that don't know where to turn to. You got it right here. Where would they call?
So in general, my office number, 954-955-4547.
4547,
I think. No,
Google
but
it.
We have a website, TM Surgical, and you can look up my name, which is not that common, and you get to it as well. And from there, we can do telemedicine. You can do appointments through the website, and obviously, we take the patient once we need more imaging. We guide the patient to the hospital and get diagnostic imaging done there, get the surgery done there, and we go from there. So,
Dr. Texidor, it has been a wonderful half hour, and I hope that we have educated you and given you some hope and some information that you'll find useful, not only for breast cancer awareness this month, but like I said, 365 days for the year. So thank you again. And thank you for joining the Community Voice. I'm Fara Sax. Keep safe, keep healthy. Look forward to seeing you again.